Right, I think we're going to start the next session. Can I ask Dr. Tahir Sagir to join me up here? And can I ask the panelists, Dr. Farhan Tayyab, Dr. General Ashur, General Saab, and can I ask my friends from Turkey, Ertan Veruskin, and Dr. Dogu Kilik, and Dr. Levant Korkmaz, I hope I can pronounce you well, Dr. Harun Babar, Dr. Farrokh Jalisi, Dr. Sohail Khan, and Dr. Usman Fahim. Can they all come up here, please? All right, I think are we ready to start? Tahir Sagir? Dr. Harun Babar, we need to start. Can we come up here, please? Let the panel settle down. Come on, friends, here. Yes. Right. So this is a joint session of PSIC and CCI Live. And we're going to start with a live case from Newcastle Freeman Hospital. And Dr. Tahir Sagir is going to moderate.
Okay. Are we live now? Okay. Hi, Nadeem. This is Javed.
Hello.
Can you hear us?
Yes, Javed, yes. We have a panel here, and Dr. Tahir Sagir is going to be the moderator. There's our friends from Turkey, and there's Dr. Farhan Tayyab, Dr. General Ashur, Dr. Sohail Khan, and Dr. Harun Babar. And they're here, and I think Dr. Khan Shah Zaman is going to join us in a minute. And so welcome here. We can see you. Can you introduce the case, and I'll give it over to Dr. Tahir Sagir.
Thank you very much. We got a very esteemed panel. Let me introduce our cath lab. First of all, on my right, we got Professor Raj Das, who is one of our interventional cardiologists, as well as an expert in structural heart. He does a lot of TAVIs as well as coronary work. And I got Dr. Mohammad Rashid, who has just joined us as a senior interventional fellow. And we got Emma, we got Rebecca, Bill, and also we got audio-visual guys, Paul, as well as Aldwin, and Andrea, who's our radiographer. The case and we have selected is according to, I think, is this a theme for calcified lesions? And this is about a 65-year-old gentleman who has got chronic stable angina, and he has got a background history of hypertension, and he is a smoker, and he had an initial cath in June this year, and after that he was planned to undergo elective PCI to the right coronary artery. We will just show the initial angiogram, and we'll see what the panel opinion is. Could you show us the initial angiogram, Andrea, please? Is it clear?
Yeah, it's clear.
So Dr. Sagir and the panel would like your opinion. What should be your approach for this lesion, which is a very large dominant right coronary artery? Yeah. And I can tell you the left coronary system is almost normal, and the LAD is a type A LAD.
Okay. Yes, Farhan Tayyab.
It looks like a very critical lesion in the proximal RCA. It's an eccentric. I can't see much of calcium there. So I would rather do it in a conventional way, cross with the wire and dilate and see.
Okay, fair enough. I think that's a good point.
And
Any other opinion from the panel, please?
And there is problem in the distal RCA also.
Hi, Javed.
Hi.
Raj, it's Sahil here.
Oh, hi, Sahil.
Looks like a challenging case that you've got for us here. So, I guess my take is slightly different on this. I mean, you know, it looks like an unusual ostium here and high takeoff, and I guess that's probably why you've got the AMPATS guide. But it does look like it's heavily calcified, or either that or you've got thrombus in that right coronary artery. So I would probably think about trying to perform intracoronary imaging here at the outset to see if we can get some information about what that lesion is, and then sort of deciding on strategy based on what I see.
That's a good point, Suhail. What we did, because he had a cath in June, therefore his right radial artery wasn't palpable, so rather than going through the left radial, because obviously we were anticipating some backup problem from the guide catheter, we went through the right femoral using 6 French sheath, and then we put, as you said, M-plus catheter, because obviously we would like to have a significant support so that we do not have to fight with the lesion. So even with the M-plus, it is slightly not sitting the way I would have ideally liked it, but anyway, it provided enough support. And I can go further if there are no comments from the panel.
Okay.
As earlier pointed out by Dr. Suhail, there seems to be a heavily calcified lesion and on top of a thrombus as well. And of course, the first thing is an appropriate support, because if you don't have appropriate support, it will become very difficult. Number one.
No, I
number
agree
two,
with you, yeah.
Number two is that you have got a right sort of catheter over there, of course. But what do you think about XB, right XB? Would that not be more appropriate? Because this catheter is not properly engaged. And
I think your suggestion is very good and very valid, but our experiences for, I mean, obviously, my default catheter is usually either AR2 or AMPLAS 0.75 or AMPLAS 1. They usually provide us adequate support in difficult cases like this. And so I think so far, what we decided to do after putting the guide catheter in the right coronary ostium, we did not anticipate any problem with the right coronary ostium because it was, the pressure was fine. And after that, but we struggled wiring this lesion. We chose a Fielder FC wire, and that was curling up in the calcified lesion. So we assumed that this is a calcified lesion, and we didn't discuss the possibility of thrombus, but I take the suggestions on board. Obviously, sometimes it is difficult to differentiate between thrombus and a calcium because this is a chronic stable angina situation. So therefore, my guess was even before we started that this is a calcified nodule with eccentric calcium. So after that, after sort of insertion of the wire to the distal RCA, we tried to test the lesion. You could see that how the wire was curling up, and but anyway, because it's a slippery wire, so we managed to get past the nodule. And I will discuss the nodular calcium management, obviously, according to our protocol, which obviously we published about 2-3 years ago. And so we managed to wire the lesion. And after that, we thought the usual test would be to put the imaging catheter. However, prior to that, we thought that we will try some form of a 1.5 balloon or 2.0 balloon. When we try to push any balloon, that will not go. So that completely changes the whole strategy for this lesion. So because
this angio that you can see here, do you think there was any suggestion of using a guideliner to give you more support?
yes, I think, yeah, Yeah, I think we thought about obviously upfront guideliner. The problem was going to be to get any dilatation balloon past the lesion or any dilatation balloon into the lesion where we can actually do the active treatment, which is dilatation of the lesion. So we decided at this stage that it would be impossible and we'll be struggling for a long time to obviously get any balloon through. Even the, I will show some further frames where even the microcatheter wasn't going past the lesion. So what we did, we decided to do the upfront rotablator, and that's, you can show that run. And so we thought that it would be impossible with traditional balloon treatment for this lesion, whether it's an IVL, whether it's what we call it, cutting balloon, or whether it's, this is a 1.5 burr. We just wanted to make enough hole because we are planned out at the front that we will be using IVL in this case. In the ideal burr with that size vessel and the calcium nodule, I would have actually used 1.75 burr to start with. But I think 1.5 burr obviously would give us some form of a passage for the balloon to get through the lesion. So we managed to, after a few passes of 1.5 burr, we managed to obviously pass the rotablator burr through the lesion. And after that, we in fact thought the next step would be to do the imaging. And that's, we did an OCT run where we could show you, and after obviously the rotational fracturing, we changed the wire to a traditional wire. Rotablation has not made any difference in terms of the plaque debulking or in terms of inducing fractures. The problem is that with the rotational fracturing, it usually cuts where the wire is, it does not induce cuts circumferentially. And if you want to have a circumferential cut, either the orbital atherectomy or the shock wave. Obviously, orbital atherectomy is usually suitable for the superficial calcium. The shock wave is useful for both superficial and deep calcium. So could we just show the OCT pictures, please? Paul?
It's on there.
So we could do that run, please. You will see that it's quite a big vessel, at least 4.950 vessel, almost. Can you stop there, please? Yeah. So you could see that there is one cut where the wire is, and that obviously would help us to facilitate the passage of a balloon, and which we tried after the OCT run, and we managed to pass a 2O balloon, which is non-compliant. However, we did not inflate the balloon because I believe in if you have IVL, you can actually induce some form of organized fractures rather than some form of disruption of the intima as well as the plaque as well as the nodule. So that's where we are. Now we are going to try an IVL balloon, although whatever so far registry data for IVL is showing that it is not the most effective treatment for eccentric calcium, because this is quite a big nodule, and the problem which we may have even after IVL is the expansion of the stent, whether we should just do IVL and leave it without any what we call it stent, and that could be a possibility if there are no dissection or anything, or so that the vessel remodels itself, or we put a stent in, and then obviously after that, if the stent is still not expanded, then we do the IVL again, which is the post-stenting. And I don't know what's the panel's opinion where we are at the moment. Hello?
I'm not sure what your guide size is, but did you think of upsizing the burr more? Do you think you'd get any more out of that?
I think we did debate that whether we should go 1.75. Then obviously this is an IVL case, and we would like to assess how effective IVL is in calcified nodules. There's not enough data available, so that would be a good test of IVL, that how many fractures does it reduce in the calcified nodule.
I think
that
we
was
were
the
also
point.
wary
There's no
that
data on
Well, I
IVL on this.
think IVL is the proper instrument to use. What you are planning.
Upsizing the burr may lead to issues with no reflow phenomena. So we were quite keen, you know, it's a huge dominant right coronary artery, to try and minimize it.
I guess one of the things is that when you're doing rotablation is that what you're wanting to do is to have a burr to artery ratio of 2 to 1. So, you know, if you're saying this is a 4.5 millimeter vessel, you really need a 2.0 burr in that. But you're going to be limited because you're 6 French, and the maximum burr you'll be able to get into the vessel is 1.75.
So Hale, this is 7 French. I think Raj's point is very valid, and perhaps the biggest the burr is, the more chances of reflow.
I mean, have you done a calcium score here then, Javed? Can you show the thickness of the calcium? Is it more than 0.5 millimeter?
I think the problem is that we do not have Ulterion software in this lab. Our Ulterion software is in the other lab. I don't know, Rashid, can you do thickness of the calcium?
But it looks like severe calcification. I don't think there is any doubt in it.
Yeah, it is calcified nodule and a big chunk of eccentric calcium.
Calcification more than, I think, 270 degrees.
Yeah, so when you're looking at calcium, there are 3 main things that you need to look at. One is the amount of calcification in terms of length. So is it more than 5 millimeters in length? Is it more than a 180-degree arc of calcium? And what the calcium thickness is. Now, OCT is very good at looking at calcium, so you can determine the thickness of the calcium. And then you can score your calcium from a score of 0 to 3, effectively. And looking at this, it looks like there's a 360 arc of calcium here, and it's certainly more than 5 millimeters in length. So I think we can certainly give this a score of 2 out of 3. I mean, one of the concerns about putting an intravascular lithotripsy balloon down here is that if you've caused some disruption in the calcium, you know, I've certainly had experiences where the IVL balloon has ruptured, and that's a costly mistake to make because the balloons are not cheap. So I just wonder whether you sort of give this a pre-dilatation just to create a little bit more space within that RCA, and then think about an IVL. But I think an IVL is an ideal tool to try and deal with concentric calcification, which is what we have here.
And to me also, with the IVL, as the other panel said, even with the fractures, there's a huge chunk of calcium protruding into the vessel. It wouldn't be possible to expand the stent, even with the fractures in the calcium,
that's what
calcification chunk here.
4 atmospheres.
Then left liver. Yeah. I think this is the IVL balloon which is going up. So we're going to deliver 40, a total of 40 pulses. Okay. 6. Okay, okay, that's fine.
I'll just come down with the balloon first. 2 seconds. Okay, down with the balloon.
Okay, just go up now.
So shockwave's ready, yeah?
Yeah.
Okay, I'm going up to 4 atmospheres. Yeah, that's 4 atmospheres.
So this is, I call it obviously active IVL balloon, and Rashid is delivering the pulses, and obviously there'll be that's it. 6 and down.
6 atmospheres.
Yeah, and down.
And down.
So we're going to repeat all these at least 40 pulses with this balloon. Yeah, let's go up again.
So up to 4. 4 atmospheres.
And 6. So basically you go up to 4 atmospheric pressure, and after that you go up to 10 pulses at a time. That is, we go up to 6 atmosphere before you deflate it.
Just push on a little bit more, fraction.
Yeah. I think as Raj has pointed out, you know, normally one should move it a little bit further. So, okay, yeah, let's go there.
Okay, going up to 4 again. It's 4 atmospheres.
Yeah, let's deliver another 10. So I think we are seeing some shock topics actually. That is the phenomena which, that's down.
Okay, up to 6.
Yeah.
And down now.
Let's do another one. Yeah.
Okay. Going up to 4.
And down. Sorry. And
Okay.
6.
6 atmospheres.
And down.
And down there.
So we have actually already delivered 40 pulses. Now there could be two choices. Either we could in fact deliver all the 80 pulses and see what the response after that, and we'll take a 4O balloon non-compliant to see if that is fully up. This is a 3.5 IVL 12 millimeter length balloon. I deliberately chose that one in case if the balloon does not go, because obviously the biggest diameter IVL balloon is 4. So we are going to use all the 80 pulses in this one. And after that, we are going to upsize the IVL balloon if the 4O non-compliant balloon does not fully inflate. So should we go up? Yeah. Another?
Okay, going up to 4 atmospheres.
Javed, just whilst you're doing that, just remind us what the size of this balloon is that you have in the
3.5.
3.5, yeah. And I have to say, this is a very good technique in terms of deflating in between
6
each of the 10 pulses.
Yeah.
I have to say, I tend to get a little bit restless and just deliver 20 in one go. And then
Yeah, I know. I agree with you exactly. Okay. Give me a second. I'm just going to see. Yeah, let's go there.
Okay. So going on again up to 4 atmospheres.
I think what we are observing is the shock topic. I don't know whether people are aware of what shock topic is actually. Because you get quite big spikes on the ECG. Yeah. Yeah. Okay, and down. So let's go up again. Yeah, let's go up. So how many pulses we have delivered? If somebody is counting? 7. Okay, okay. Okay, let's deliver the last 10. There we go. Okay. Let's go up there. Yeah, that's fine, yeah. And down. Okay, so now this balloon hasn't got any more pulses, so this is a redundant balloon, so we have to take it out.
Would you consider just inflating that balloon at the lesion now? You've got a 3.5 in there.
No,
anyway.
no. I never do that, so that is the problem, you see.
I mean, it might be a good idea to re-image now to see if you've made any impact on that calcium, or are you going to put an NC down?
I'm going to do a quick angiogram. You see that we got better disruption now.
It does look better, doesn't it?
Yeah, it does look better. And
Lumen's
our
increased
next
in
step
size.
would be to use a 4O shockwave balloon. And I don't think it's going to show a lot on OCT. And either we can do imaging now, or we can...
I mean, take an NC, take a 4.5 NC, see if it's...
Okay, let's have a 4.5. I think Raj suggested that 4.5 NC. We'll see how much inflation that balloon actually gets and how much the lesion it occupies, you see.
to modify the lesion.
That's right, yeah.
You know, get a sort of 1-to-1 ratio with the NC balloon.
I think there is no right or wrong whether you use the NC balloon before shockwave, after shockwave, and because we have just submitted we have already published the first real world experience of our shockwave cases. We have just submitted, we are waiting to hear our left main experience of shockwaves, you see. There are over 80 patients with left main, and we have compared that with rotablator. So hopefully, if that is published, that would be a good real world experience.
Could you just remind us what your OCT measurement was for the normal
With the lesion?
It's about 4.95.
Can I
so
ask
we got a 5.0 stent which we can put, but I mean, if the panel agrees, we can go with a 4.5 balloon as well.
Yeah, I think you should go with the balloon.
That's what I'm thinking. Go for a 4.5.
To prepare the bed much better, more.
Can I ask a question as well, please? Hi.
Yes, of course. Yeah.
Prof, it's Ali Raza here. So my question is that, have you ever considered using a cutting balloon post the shockwave to see that if it works, rather than taking another shockwave bearer balloon?
I think that's a good question, and that's a good point. We have found that out of all the calcium layer modification therapies, and cutting balloon is the least, what we call it, trackable, in lesions like this. I mean, it may have gone. So,
case, isn't it?
Yeah. So we are just now inflating this 4.5 balloon now. See what it shows. I think still there's a waste. Come down. Yeah.
Okay. Yeah. It's 14 atmospheres.
You may need a cutting balloon now. Would you like to use a cutting balloon now?
No, I think I'm going to try 4.0 shockwave now.
How high did you go on that NC?
That was 14 atmospheres.
So we're going to we're going to go for 4.0 shockwave.
Did you want to go with a higher pressure on that NC?
I think I'm a little bit skeptical in calcified lesions, because we got now therapies which can actually induce cracks and fractures in the calcium. So why to take a risk of going about to 22 atmospheric pressure? I think that's always the worry. That is the problem. So I would rather use another shockwave balloon.
Or maybe an OPN. What about OPN?
Yeah.
4.012, that's fine.
They can go.
So great.
I think one of the problems is shockwave is very effective, but the problem is the expense. It is an expensive balloon, especially when you combine it with rotablator, which we call it rotatripsy, and that becomes even more expensive. I think one of the problems is if the stent is not fully expanded, I may have to accept reasonable cross-sectional area with, even if it is an oval-shaped lumen at the end. I mean, after the stenting, you say. We may not get an ideal result here with the very circular looking stent with the minimum stent area of at least more than 9. But I think sometimes, you cannot achieve the perfection in any lesion.
Would you consider it without leaving a stent at the end if you manage to open a sufficient area of lumen?
So you mean without putting a stent in?
Yes. Considering, if you can't really gain a lumen area, and if you cannot be satisfied with the stent expansion?
I think in a 4.5 vessel, the ideal MSA, which is minimum stent area, I would like to have is 12. But anything close to 9 or 10 in this artery, even if it's the oval-shaped lumen, I would be very happy with that. There we go.
What is your anticoagulation for this patient?
So he's had 8,000 units of heparin at the start, followed by another 2,000, another 2,000 of heparin, so 12,000 in total.
That's a good
and we're
good
maintaining his ACT above 250.
So we are going to go up with the 4O shockwave balloon. I've just put it in the, what we call it, here we
So
go.
we're ready to go, are we?
Okay.
To acquire pulses, that's 4 atmospheres.
Can you bring it further, otherwise it's dragging on the balloon. Thank you. And down. And down. I think we will give some breathing space to the artery before we induce another 10 pulses to this huge artery. Oh. Okay. Can you just put it in negative? Okay, give me a test. Okay.
4 again? 4 up.
Just trigger it, yeah.
See the waist.
Yeah. And down. Yeah. Yeah, let's go.
Javed, are you still
so
getting those shock topics with these?
Yes, we are.
I don't know if you can show your physiology screen.
Can we show us
there,
this? I don't think there's
that.
any live feed for the screen actually.
Ah, okay.
And
because it would be nice to demonstrate to the audience
and
what shock topics are.
And down.
Maybe you can just explain what they are, Javed.
Basically, they are pacing spikes which we get it, and I mean they are really benign, but sometimes it can induce some arrhythmias. Okay, let me put it back. Okay, let me just. Okay, let's go there. It looks like it's fully up, but again it's going to eccentric calcium, you say. So, and down. How many pulses left? 3. 3 more. 4 more, okay. Let's go further.
Okay, up to 4.
Yeah.
I guess you just go and deliver all of the pulses in the vessel, don't you?
Yeah.
I mean, you can get misled, of course, because if you've got a balloon up at only 4 or 6 atmospheres, then it's difficult to know if it's fully expanded. So I think even after this, you're probably going to need to take a non-compliant balloon to reasonable pressure there.
Yeah.
Okay. It's down. Yeah.
Okay.
Do you want to do one more? Or
let's do one more.
Last one. Okay. So up to 4 atmospheres again. You can just acquire their sheet.
I think we are never going to get a full expansion of this stent, because obviously, because of the eccentric calcification and down, and also the nodular nature of this calcium. So we're going to take this balloon out. Yeah.
Heparin. Can you give another 2,000, please, Bill? Yeah, thank you. So Sohail, we're going to take your advice and we're going to go back with an NC now to a higher pressure and just see if the balloon comes up, a bit better and there isn't waste on it, and then reconsider what we do next, whether we stent or whether we need to do some more calcium modification.
Would you consider repeating your OCT after this step?
Yes, that's what we are planning to do. OCT after this non-compliant balloon. I think we got our senior fellow who is very good, hopefully, at injecting.
Javed, can you take a shot?
Just a bit more. That's great. It's just negative now.
Javed, can you take a shot after IVL?
You do.
Oh, okay, sorry. Yes. Yeah. I think the lumen is looking much better. Can you just record that, please? And can you just show us, please? So this is the shot after the second IVL balloon.
Just get your wire. Well, happy with your wire now.
Yeah, thank you. Okay, we are right.
Little test?
Yeah. Okay. Let's go there. Yeah.
Okay. Going on now. This is the 4-5-15 balloon.
Just
Come up. Yeah.
That's
That's 14 atmospheres.
And down.
And down.
Yeah. Could we have that, should we have a 4-5 stent or 5? We are debating what size stent we should have, 4-5 or 5-0.
I think take a.
How much pressure you have gone to?
We have gone up to 14 again.
Up till how much pressure?
14 atmospheres.
14.
20 पे जाए ना 20, 22.
Thanks, Paul.
Is that the OCT?
It's good. So let's take a 5-0. It's a 5-0 vessel, and we'll go low pressure.
Okay, yeah.
So what have we got in a 5-0? Yeah. Take 5-0-15, I think.
Do you want to do OCT at this stage or?
I mean, it looked like you had good expansion of your 4-5 non-compliant balloon, so...
Looks like, yeah. I think we can do a quick OCT run, yeah.
Yeah, I mean, it's just going to take 30 seconds, so it'll be good for the audience as well. So if you could manage, that would be great. And it would be nice to see if the IVL has caused any disruption of the calcium.
Absolutely, especially fractures, I call it, you know.
Can I ask Professor Khan Shah Zaman to come on the stage for as a panel of chairmen?
So it said that you'll get equivalents of around 50 atmospheres of pressure with the IVL balloons, don't you? So that's a lot higher than what's achievable with non-compliant balloons and also with high pressure OPN balloons as well.
Sorry.
Javed, I think we are in time, but you are left with 9 minutes for your transfer.
Okay, no problem.
That's fine there.
Okay, that's fine. Okay.
Just get the syringe. That's lovely.
Have we got an inco pad, please?
Okay, right. I'll fill the guiding catheter.
Let's see.
Okay, ready to do a run?
Okay.
Contrast clearance might be an issue because it's a massive vessel that you've opened up here.
Yeah, yeah, absolutely, absolutely.
Give it a good welly.
Okay.
Yeah. I think Raj has done a wonderful job again.
Beautiful.
Let's have the stent, please.
Okay, we'll come out with this.
Yeah. Yeah.
Okay.
Did you decide to go with the 5.0 stent or 4.5 and then?
Yeah, 5.0,
high
5.0,
pressure?
5.0.
Just take the stent now, Rashid.
So I think you're back in the guiding catheter there, but can you take it back to the lesion, because I think we can see some clear disruption.
I think we
of the
have
calcium.
gone through the lesion. Could we go back to the lesion,
Yeah,
please?
just bring it back to the
Just on
lesion,
that.
because
Absolutely, yeah.
so you can see the lesion's opened up really well here, and if you take it further back, actually, what we also see is some thrombus. Just there, if you pause it there.
Yeah, yeah, if you stop it there, yeah.
Yeah, just
no,
take
where
it back
there are
a few
fractures,
frames.
Yeah.
Yeah, and
You
just
take
let
it
it
back
play,
few
and
frames,
just
please.
pause when I
Yeah.
say pause.
Yeah.
Yep, just pause there, pause there.
We can see fracture, yeah. We
Yeah,
can see fractures, yeah.
here at sort of 11 and 12 o'clock, what you can see is sort of microfractures that have been caused by the IVL balloon here. So, and we know that actually the 4.5 NC balloon has gone up very nicely. So, I think it's probably time to go ahead and
got
put
your
the
wire.
stent in.
So it's a 5.015, yeah? Great. Good.
Fantastic. That's all right. Let's do a cine, yeah. Yeah. I think I'm happy with that. Should I move just a little bit? Can you give a test shot? Yeah. Yeah. Okay, let's go there.
Nice and still.
11, 12.
That's good. It's 12 atmospheres. It's come up nicely, hasn't it? Yeah.
And down.
And down. Great. Pressure is good.
We can do another OCT run.
We'll just show it angiographically first, maybe,
Yeah.
and then...
You've got 5 minutes here, Javed.
Oh, we've got 5 minutes. Okay,
Yeah.
great.
But it looks like you had really good expansion of the stent there, so I'm sure
I
you're
hope
going
so.
to get a
We
fantastic
just-
area on this.
Oh, that's good.
I think it looks good on an
Seems to be
angiogram.
pretty good, yeah.
Looks marvelous.
So, do you guys want an OCT run or?
I think you should give yourself and your team a big round of applause there, Javed.
Well,
That
thank
looks
you.
fantastic.
We can do a quick OCT run.
Yeah,
you know,
why don't
like-
you do that?
I think Raj chose 5.0 stent because I was thinking of more of 4.5, but I think that is a good point because we only went up to 12 atmospheric pressure, you know. So calcified lesions, you have to treat them with a little bit of respect, actually.
And the vessel on the OCT was 5 millimeters.
Yeah.
Yeah, the reference vessel diameter.
Javed, Assalamu alaikum. This is Bashir. How are you?
Hi, Bashir.
I just wanted to ask you, great case, like we don't have IVL yet. So in such a
Yes.
case, what would you suggest we should be doing in Pakistan?
I think the big calcium nodule, a rotational athectomy with a big burr, to be honest with you, starting with 1.5 or 1.75, and after that keep on upsizing the burr till you have actually induced fracture. And the second thing is, I don't think what's, we call it, orbital athectomy works. I think this OCT catheter refusing to go, so I think I don't want to disrupt the stent, so probably we got good angiographic results. So I think the answer is rotational athectomy because, in fact, the rotatripsy, which is obviously rotational athectomy plus IVL, is ideal treatment for calcified nodules. But I think we don't have IVL in Pakistan. So in my opinion, the best thing would be to obviously upsizing the burr and starting with the, I wouldn't start with the 1.5 burr unless and until it is a 2.5 vessel. But I think in a bigger vessel, and a bigger burr is obviously the answer with a large bore guide catheter as well as a sporting guide catheter.
Why not orbital atherectomy? Why do you think it won't work? Because that's what's supposed to be like today. Fahim showed a case. It was a larger vessel and we thought that orbital would work better.
I think orbital atherectomy would work better, but the problem with orbital atherectomy is that it basically gives I mean, it is a 360-degree sort of treatment of calcium, but obviously I think the vessel perforation rate is higher, and I don't have no experience of orbital atherectomy. I think Sohail may have done few cases, if I'm not wrong.
Okay.
So we can show the last picture of the angiogram. Yeah, and thank you very much for giving us a chance to show the angiographic sort of as well as the OCT aspects of modification and treatment of severely calcified and eccentric calcified lesions.
Thank you very much.
Very satisfactory results, Dr. Javed.
Great result.
Nice work.
Thank you very much.
Javed, I have a question for you. How much is the risk of perforation of or coronary artery spasm with this procedure?
I think as long as, because another important point, we used extra sport. I usually use extra sport rotawire. The advantage of that is usually that the wire doesn't come out and it provides a good support and the burr doesn't sprawl actually. So generally the risk of perforation is there with rotational atherectomy, but luckily this vessel was a little bit had a straight run. So the risk of perforation was less than what obviously another vessel would be. Okay, no problem. Thank you very much.
Thank you.
Well done.
Thank you.
Thank you. Okay, so let's move on to the next.
Now our next talk is by Mohaned Egred from UK. He will be talking about the best strategy to trim the rock, tips and tricks of IVL. Mohaned.
I think this talk comes handy with just we've seen.
Okay. Mohaned,
can you see
my slides? Can you hear us?
I can't hear you. Can you hear me?
Yeah, we can hear you.
नहीं नहीं बहुते सामने नहीं बोल रहे हैं वो ऐसा तो चूड़ा है
Can you see the slides?
सामने बहुते सामने कुछ नहीं कर रहा है बस बाकी हमारे उससे जड़ा ना है हम भैया नहीं होंगे टटर करते MQM वाला है तो सब भैया पैसे MQM
Can you see the slide? Can you hear me?
क्लियर होंगे नहीं
जगह पे अवेलेबल है पाकिस्तान में जी हमारे पास FSE में भी है.
Can you hear me?
Yeah, I can hear you, but yeah, I can hear you.
Can you see my slides?
We can hear you. You can go ahead, please. Can you hear us?
Can you see the slides?
No,
Not yet.
I can't see the slide.
Right.
But I can
Let me
see,
share that again. I'll share that again because it's. Can you see the slides now?
No, but it's not shared in our screen.
Now we can see it.
Now the screen is shared.
Okay, good. Good afternoon, and thank you for the opportunity to produce. I think this talk comes very handy after the case you just saw. These are conflict of interest. What I'm going to try to do is just talk about the effect of calcium, how you detect it, and how you treat it, and focus more on the IVL, as I was asked to speak a little bit more on IVL, which I just said that it's still not available in Pakistan, but it's good to know about how we are using it currently. And we all know that calcium is becoming more and more prevalent because we're treating aging population, more comorbidities, people are living longer, so there's more calcium in the coronary arteries that we have to learn how to deal with. And similarly, they are among the highest risk lesion because with the difficulty during the procedure as well as the long term, they have a major effect on all this. So of course, the implication for coronary calcification can result in the difficulty in reducing or delivering the stent, achieving a good outcome in terms of the dilatation of the vessel, the good opposition of the stent and the symmetry, etc. And of course, as you just saw, if we did not prepare that lesion very well, the stent might not have expanded very well, and that would lead to a long-term effect in terms of restenosis, occlusion, and thrombosis, which can carry kind of a significant morbidity and mortality. So really, lesion preparation is paramount. You have to make sure that you prepare your lesion very well, because that will allow you to finish the procedure well, and also to deliver the stent to achieve a very good results. And I'll come to that in a minute, but let's focus on why calcium is quite important. We know that severely calcified coronary arteries could lead to one of three things. First of all, the increased safety risk, because when you're trying to produce or to kind of dilate the vessel with lots of calcium, you can produce major dissection, you could have perforation. That's not an easy thing to deal with because you don't have enough access to put a covered stent, which is more bulky than a normal stent. And of course, if you have not prepared the lesion well and there's still lots of calcium, as you can see in the middle of the slide, the stent will become difficult to deliver. It could even strip off the balloon and get stuck in there. So it's quite important to make sure that your lesion is well prepared. And of course, if the calcium is not very well dealt with, the stent will not expand very well. And we said that already, that could lead to more restenosis, more thrombosis, and occlusion. And that could have a catastrophic effect. So heavily calcified lesion is associated with procedural as well as a long-term poor outcome. And of course, in terms of when you're assessing the lesion, if this was mentioned briefly, you have to look at the calcium, the arc of the calcium, the length and the thickness, because all these in total, you could look at them in general and kind of come to a conclusion what you need to do best and how to prepare the lesion best to make sure that when you put your stent in, it is going to be well expanded and you achieve ideal result. So how do we detect calcium? It's always been through angiogram. I don't know, these don't seem to be playing. So usually a moderate calcification, you see it only during cardiac motion on one side of the vessel. In severe calcification, even without the cardiac motion, you could kind of ascertain where the arteries are, and usually it's on both sides of the vessel. But of course, angiogram is not very specific because you will not know where the calcium is. Is it in the adventitia? Is it in the lumen? Is it in the media, etc.? So this is kind of a crude way of looking at what the calcium is. And of course, this is where you understand that calcium is not only in one shape. This is where imaging comes in. You put your IVUS in, for instance, or OCT, obviously, and you look whether it's moderate, it's less than 270, 180 to 270, severe is more than 270-degree arc. And of course, there's not one kind of calcium, as this slide will show you. There's deep calcium, there's superficial, concentric, eccentric, and the nodules, which are probably the most difficult one. And the previous case you saw was quite a good demonstration of what the nodule could be. And there are multiple ways of assessing the calcium and reaching a conclusion to how you deal with it, either with OCT or IVUS with some different grading depending on whether the calcium, the thickness, the arc, and the length. And of course, now we have the Ultrion, the OCT, which is automatically detects calcium and give you that degree of certainty in a way that this is how much calcium you have, this is the arc, and this is what you expect to, the difficulty in treating this. So if you look at the OCT, if you look at the angle, you give it points, whether it's more than 180, then it's 2 points. Of course, the higher the points, the more difficult treating this calcium will be, and the more significant the calcification and how you have to concentrate and making sure that you are dealing with this calcium in the right way. And similarly, this is the same with IBIS. IBIS is a little bit probably because you don't see what's beyond the calcium. But of course, you could assess it based on the length, based on the arc of the calcium, and whether it's a calcium nodule or not, and the size of the artery. Again, you get to a conclusion or a score, and then you could consider atherectomy based on your score and what to do with it and where the calcium is. And don't forget, calcium nodule remains probably the most difficult part of this, because as they are eccentric, and there are two kinds of calcium nodules, the eruptive one, which is the most difficult one, and then the nodular, which are usually healed calcified nodules, covered by a smooth, thick, fibrous cap. So what are the options to treat and modify coronary calcium? As you will know, and many of you would have seen any of these, you start from non-compliant balloon to the cutting balloon, scoring balloon, and also the high pressure balloon, which I have to say I don't use these very often. And of course, then it comes the more expensive and more specific treatment, laser, rotablation, orbital atherectomy, and of course, lately IVL. All of these have their own use, and all of these are available in different cath labs, depending on where you are. And if you remember, this is kind of a way of remembering what they are. The role word, rotational atherectomy, orbital atherectomy, lithotripsy, and excimer. That's the role. The non-role, as we mentioned, non-compliant balloon, cutting balloon, scoring balloon, and the high pressure balloons. And of course, each one of these will have its own kind of drawback or limitation. With the balloon in particular, the high pressure balloon preferentially expand away from the calcium. So you have a higher risk of perforation, a high risk of problem. The same thing with the infiltration, predisposed to high risk of major dissection, as well as perforation from before. And typically, if there's a deep calcium, the balloon usually will not affect that. What about rotablation, atherectomy? I think rotablation is one of the most effective ways of dealing with calcium, at least up till now. And although it does have some limitation in the way that the rota wire is a specific wire, you need a dedicated one, thin and flimsy. You have to make sure you handle it well so it doesn't bend and cause you any problem. There's a thermal injury, so you have to make sure that your burr is moving, you don't burr for too long. And of course, distal embolization with no flow, particularly in long lesion, and particularly in cases where there's a lot of calcium, is quite an important one. And treating no flow can be quite really difficult. And of course, the ablation is dependent on the contact. You've seen that quite often all what I use is extra support rota wire to give me that little bias, particularly in big arteries, because that's where the rota burr will affect. And of course, there's the theory that you don't protect the side branch. I don't think that's a major problem, and usually it doesn't cause much problems. And of course, the treatment or the training in rotablation takes a little longer. You need a good experience, you need a good proctorship to be able to handle it and use it in difficult or different situations. So what about IVL then? IVL has come on the market, and I think it's quite a revolution to how you handle calcium. And it has two unique mechanisms. It's usually focused lithotripsy energy is created at the emitters, where the electrical energy delivered to the emitters, which are surrounded by the balloon and the fluid, and that creates a sonic pressure wave that allows to kind of steam bubbles to form, expand, and then collapse, and that's affect the calcium and break it. So as I said, designed to minimize the trauma while cracking the calcium. Why is that? Because IVL will be hard on hard tissue, i.e. the calcium, and soft on the soft tissue, so it doesn't injure the coronary artery. In the same token, that might be kind of a drawback, particularly when you're treating an eccentric calcium or nodule. Of course, the mechanism of fractures, 5 of them, and I won't go into too much details, but this is basically how it affects the calcium. Compressive, shear, spalt, tensile and squeezing stress. All this lead to fracture of the calcium and make life much easier to deal with it. And of course, this is only what we see on OCT, but of course there's microfracture that has been shown in high resolution eye vessel OCT or even CT, micro CT. So you can see that there's more fracture than appears to the naked eye. So some of the advantages of this is you could do it on a normal wire, normal angioplasty wire. You don't need the same wire as the rotablation. It passes through the black vessel wall, enabling modification of deep calcium. In contrast to for instance, the rotablation that doesn't reach deep calcium, or the balloon that doesn't affect the calcium deep one. And similarly, the disrupted calcium remains in the wall. It's not broken into small particles. So the distal embolization does not happen very often, and you don't have the no flow. And of course, it's allowed the modification to perform at low balloon pressure, so avoiding the risk of associated high pressure inflation, i.e. dissection and perforation. That doesn't mean it doesn't happen. You could still see that. We had some balloon rupture, or we had some perforation in the vessel. But of course, this is very, very little in comparison to other methods. And of course, you could put a wire in the side branch without any problem. The main thing about the IVL, it's easy to learn. It's basically delivering a balloon to the lesion and delivering the energy. And that's much different from rotablation, obviously. So basically, the balloon will emit the high waves. Sorry? And then the reflection of the calcium amplifies the effect. And the heavily calcified lesion, usually the one that gets fractured the most. But of course, there's the last one, which is, I think, the important one to understand. The dissipation of the therapy through non-calcified vessel wall, which means in eccentric calcium, where you have an area of the vessel that doesn't have calcium.
Mohaned,
that's what I'm experiencing.
We have time limitation. You have 10 minutes to talk about, and now your 10 minutes is over. You can wrap up the things within 1 or 2 minutes.
Okay, sure. I'll skip through this. So where can you use it? In calcium morphology, concentric, thick, eccentric nodule. I put a question mark on these two because they're not as effective. Left main, RCA and CTOs, and of course, if it's too long lesion, then you avoid the risk of no flow and so on. You could use it in the peripheral vasculature too, but I won't go into details on this. So practical tips, you really have to size 1-to-1. You really prepare very well 50-50 and move the balloon between the inflation to optimize the opposition of the emitter, because that's where the most energy comes in. And all sizes can be delivered through the 6 French guide extension or guide catheters. And when it is difficult to deliver, you could inflate and deflate. Of course, the pulse are delivered in 10 and about 10 seconds. If you are concerned, particularly if you're doing a left main, you don't have to deliver the 10 pulses. You could deliver 5 and wait and repeat the other process. Imaging is important. I say a must, but I just heard that in Pakistan, there's only about 5% who have that. But imaging will allow you to diagnose where the calcium is and pick which area, which method you're going to use to treat it, and which adjunctive therapy you're going to do. And of course, there's lots coming up, data emerging as we go along. Lots of algorithms right now. I won't bore you with this. Different algorithms from different places. But again, once you understand the mechanism of each one of these, you'll be able to apply it in your day-to-day. And of course, it would be very good, I don't know if this will play, if you could have something that will deal with any calcium, such as this. That would be an ideal approach. With this, say thank you, and I'll take any questions.
Thank you. Thank you for the nice talk.
I would like to just ask one question. Is it in heavily calcified lesions like we saw the previous one, is it necessary to combine both the modalities like rotablator and IVL, or is IVL sufficient to deal with it?
Dr. Sohail Khan, can you answer this?
Yeah, I guess the challenge in that live case was that there was difficulty in getting equipment past on the wire, and wiring was tricky. So some sort of lumen had to be created. Now, whether you do that with laser or rotablation, as they did in that case, I think that was what was important there. I mean, this is an established technique known as rotatripsy, where you use both rotablation and IVL, and I think they're complementary rather than exhaustive technologies. Yeah.
Dr. Farooq Jalisi?
Yeah, I have a quick question, actually. If the physics behind all this is lithotripsy, then why do we need different sizes? Why do we have to have contact with the intima for the lithotripsy to work? Why can't we just change frequency or something else to make the calcium break? So I haven't quite understood that part. Go ahead.
Yeah, go ahead, Mohaned.
Just because the energy will dissipate. If you're not against the wall, the energy that's created is just dissipate in the artery, and you do not affect the calcium.
Right, that's what I'm saying. So why not have an ability to change the energy rather than change the size of the balloon?
You can change the energy as much as you want. If there's no contact with the wall, the energy will dissipate in the artery and will not affect the calcium. And hence the importance of choosing 1-to-1, and that's why you need to do it. I'll just take the back to using the rotablation and the lithotripsy. In probably 1 to 2%, you will need to use 2 modalities. But I think there's a lot of what I see right now using a small burr, like 1 to 5 burr, and just switching to lithotripsy or IVL. It's quite an expensive way of dealing with calcium, but it is needed occasionally. But if you can do it with one modality, probably that's the better option, i.e. choosing the correct size of rotablation.
So my question was based on how lithotripsy is used in nephrology, where you increase the number of sessions or time rather than anything else to get effective treatment. So why can't we do that in coronary vessels? Change the frequency or time?
From my understanding how this works and the mechanism of this, you could change the energy as much as you want. As long as you don't have contact, you're not going to achieve an outcome. But that's probably a question for the engineers, how to do this.
Okay, thank you, Mohaned. It's very nice to have your talk and then discussion. Now we'll take our next talk, pearls and pitfall of treating calcified lesion, case of un-dilatable lesion, presented by Salman, Ishaque and Adnan Kaya.
Can I present? Yeah. Hello. This is Dr. Adnan Kaya from Istanbul, Turkey. Just before my talk, I want to thank to my mentor, Professor Dr. Ömer Göktekin, who gave me the chance to work with him as a fellow for 1 year and learn a lot of things about complex cases and CTO. So today I have 2 cases with heavily calcification. The first case is a case of heavily calcification that stent implanted, then after complicated with acute stent thrombosis and cardiogenic shock. So the case is 55 years old male. He has hypertension, diabetes, and smoking. He had surgery for 11 years ago and admitted with non-ST elevation, myocardial infarction, and ongoing chest pain. The ejection fraction is 30%, and he has moderate MR. And the first angio and interventions were done in outside hospital, and the angio showed RC CTO with distal filling both from the ipsilateral collaterals and left system. We can easily appreciate that it's a calcified RCA long CTO. So here we can see that the lima is occluded also, and no other SVG grafts were detected. So this is the left system angiography, and we can easily see that LAD is heavily calcified from D2 to LMCA. So because of the non-ST elevation presentation and ongoing chest pain, it was decided to do PCI to LAD. And it's wired with regular wire and dilated with 2O15 balloon. So after that, the operator decided to go for stenting, and 275-28 DS was implanted at the proximal LAD. And at the stent clear, we can easily see that the distal part of stent is well opened, but the proximal and the mid part of the stent is distorted and is not opened. So they did NC dilatation with 275-15, but after that also stent clear shows that the lesion is not dilated well and the stent not expanded well. After that they went for a small NC balloon, but they gave up with these images. They end up the intervention because they don't have open NC high pressure balloons or other options. So 3 days later, after discharge, the patient presented with acute pulmonary edema and chest pain, and the angio showed stent thrombosis. So there again, they went for NC ballooning, and the vessel were opened. So again, they discharged the patient, and the patient again admitted with chest pain and heart failure, and again NC dilatation, and the flow was restored, and the patient's clopidogrel was changed to prasugrel. After that, the patient was sent to our hospital for this calcified undilated stent. So we decided to go for rota stent ablation for this case, and this is the first angios at our center, and we wired the diagonal, and we see the situation. Then after we changed our wire to rota with microcatheter, and we did the rota run. After rota, the lesion was dilated with 275 8 millimeter NC quantum apex, and we implanted our stents. So after stents and after optimization, we had a nice result. At that particular case, we need to open the LAD because there were no grafts, working grafts, and the RC and the L6 were not good. So for this patient, it was an obligation to open this vessel. So for this case, take-home message will be optimal lesion preparation with 101 NC balloon is needed. Whenever we cannot dilate a vessel, we have to not to stent it. So if we stent an undilated lesion, it can go with acute vessel closure, acute stent thrombosis, and a rupture. And if we have a calcified vessel, we can go for open NC, cutting balloon, scoring balloon, rota, and shockwave. So can I go for the second case?
Was I was done at any stage in this patient? I was
actually we did it, but I don't have the images. Yeah, for vessel sizing. So.
I think while they put up the next presentation, we have Dr. Wahaj Haman on virtually. Wahaj, are you there?
Yes, I am.
Okay. Are you using IVL or like in your practice?
Yeah, so it's actually been pretty revolutionary. I practice in a peripheral hospital in a large hospital system, and so there's a lot of hesitancy initially with rota ablation and CSI, but with the advent of IVL, it really has changed a lot of the ways we practice, in that these highly calcified lesions are now being prepped within these sort of smaller peripheral hospitals, which has really changed the game for us.
So what's the exact mechanism of IVL? We were discussing earlier, I know you were there. What do you think, how does it really works? What Dr. Farooq Jalisi was asking about changing the energy or time, why do you really need different size balloons for IVL?
I would agree that that's more of an engineering question, but my understanding again is that it has to be opposed to the vessel for it to have the maximal effect, especially when it comes to the deeper calcium. I guess we need more contact with the vessel in order to adjust the vessel architecture.
And when would you consider straight going to IVL instead of even not thinking about orbital or rota?
So if the IVS catheter passes, specifically the Philips one, it's much more bulkier. If that passes, I think I would go straight up with the IVL. Of course, every case is different, but that's sort of a crude measure of where we can go with IVL up front.
Did you see the case previously which was being done from Newcastle? I was
Yes.
asking why not use orbital orthorectomy, and Javed didn't have much experience in that. Do you have any experience telling, do you think orbital would have worked if you don't have IVL in that case?
I think that both of them are rotational atherectomy and CSI are both very good tools. It really depends on your comfort level. I think it would have worked just fine. More than I think the size of the birds, how you use it, your technique. And so with the CSI, in my opinion, if you're just slow and make multiple passes, I think you could have modified the calcium within the vessel.
Thank you so much.
Thank you so much.
Dr. Adnan.
So I'm sorry, I need five more minutes to present my second case. So there's another calcified case which we use rota and shock waves together. So this case is 51 years old male. He has prior PCI to RCA with myocardial infarction. He has a fourth angina and he has viability in LAD territory. The ejection fraction is 30 to 35%. The diagnostic angio showed proximal calcified, heavily calcified LAD, tight stenosis. So from the other weaves, we can easily see that both sides of the vessel is calcified. The diagnostic angios images are like this. So we shift from radial to femoral due to radial spasm. So we start with dilatation of the lesion with 2.515 NC ballooning, but nothing happens. Then after we shift to 3/12 NC balloon, and again the lesion doesn't expand well, and we can easily see that the dog bone effect. So the proximal part of the balloon is expanded well, but the mid and distal part of the balloon is not expanding, and we see both sides of the calcium here, like this. So then after we did the rota, and 1.75 Burr rota across the lesion. So this is the second run for rota. After rota, we did again high pressure NC ballooning and scoring balloons, but the calcification doesn't expand. After IVUS, we see deep circumferential calcium without cracks. So we decided to go for a drug-eluting balloon for 1 minute. Then after elected to pace the patient for a shock wave for another session. So these are the images of the patient after the intervention and the drug-eluting balloon. The flow is nice, but the calcium is there. So we elected patient for a live case. Now we are dilating the calcified lesion with NC balloon with high pressures, but it's not working well. Now we are preparing for shockwave, and we applied shockwave. Can we go faster a little bit? No, 1 minute back, maybe, for the last video, last images. 4 minutes video, just last 1 minute. So after shockwave and dilatation with NC balloons, we were able to open the vessel. We have 2 minutes to go, I think. Yeah, let's see the result. I'm sorry to make you wait, but yeah. So after shockwave and NC dilatation, we had nice results of the vessel, and we stented it nicely. So in this case, the aim of presenting this case is to show that sometimes we are not able to open the vessel with NC balloons, scoring balloons, and we have to follow up the charts, treatment charts, and in this particular case, we followed all the ways down, and after shockwave, we had a nice result. Thank you. Thank you. We can go.
Thank you, Adnan. It's a nice case. Now I would like to call upon Dr. Salman Ishaque to present this case.
Assalamu alaikum, everyone. Un-dilatable lesion. Can you play my slides?
Dr. Tahir Sagir, during this interval, so what the message we are getting is that these both modalities are complementary with each other, the rota and the IVL. So where the rota is not fully successful, then you can go on and do things with the IVL.
My question to Dr. Sohail is that has IVL potential to replace rota as a technique to treat calcific lesions? Seems to be much more easier to use.
Yeah, no, absolutely. I mean, the technology is very, very easy to use because actually all it requires is for you to be able to put a balloon into the artery I think it's not going to replace rotablation completely, because you will be in situations where you will not be able to deliver your balloon through a calcified lesion despite your best efforts. So I think there's always going to be need for use of rotablation. And actually the other technology that we haven't discussed is laser atherectomy, which is also a very good technology to be able to use if you can cross with a wire but are unable to bring any small balloons down.
So I'm Dr. Salman, Ishaque, Interventional Cardiology Fellow at Tabba Heart Institute. I'm going to present a case of a balloon un-dilatable lesion here. This is a 70 years old male, known case of hypertension, had cabbage in 2016 with grafts for Lima to LAD, SVG to RPD and OM. He had a graft study in 2019, showed patent grafts and was medical treatment since then. His presentation was kind of atypical. He has mostly non-exertional chest pain for last 3 months. So non-invasive evaluation was done, showed medium-sized LAD ischemia with transient ischemic dilatation, and his ejection fraction was normal. So based on scan findings, coronary angiogram was done. So click कीजिएगा. लेनी जी सर, अभी सुबह भी चेक किए हैं तो दी
So what is the then difference? One is the IVL, the other is the laser. Right. So where do you use the laser, and where do you use the IVL?
So this is the angiogram showing
lesions.
moderate to severe osteoarthritic disease, while LAD has severe disease in osteal segment. While LAD is severe disease in osteal segment.
Access.
And
sure.
Right? Even your 2 millimeter balloon is not going to, IVL is not going to.
The right coronary artery is distally occluded, and on the right is a graft angiogram. The graft OM was patent. Well, Lima to LAD was also patent, but
what I'm
you
saying
can clearly
is
see that the side branches of Lima are not ligated, so there is some element of steel there.
But that is also
And the graft to RPDA was also patent.
POs and calcified lesions.
So based on the scan findings, we decided to proceed with the PCI.
You have to be in the lumen, yeah. Okay.
Patient had moderate to severe disease in osteal cervical, severe lesion in osteal LAD, while his graft to OM and PDA was patent. Lima to LAD was also patent, but you can see the side branches of Lima were not ligated during surgery, and so we suspected some element of steel there, and this was our plan to stent left main to LAD. So I would like experts to comment on that. So if they want to do anything different on that.
Basically, but the side one is not. So there is a streak in
osteal LAD has. But there was a severe lesion in osteal LAD. I don't know. You can.
I can't understand either. Either नजर भी सही नहीं आता ना. अच्छा सोहेल, ये जब आप लेजर की बात करते हैं तो लेजर भी
It was kind of severe in osteal LAD.
रिप्लेस कर रहे हैं IVL को.
Okay, Baba sir, Arun Baba, what would you suggest?
Sorry, I can't see actually properly. It's not fully visually. Can he repeat it again? If then we can.
Let's go with PCI. So we decided to proceed with PCI of osteal LAD. So we've decided to put in stent from left main to LAD. We decided to pre-dilate. There was angiographic moderate to severe calcification, so we decided to proceed with pre-dilation with NC balloon 3.5 into 8 and score flex 3 over 15 at 8.
I think it's not working.
आपको proper नजर आया?
That's fine.
I think due to technical
He's saying that
Dr. Salman will present his case tomorrow. We will adjust the time for him and we will review the case and then discuss. Thank you. Thank you for the panel of chairmen for taking such a nice talk and discussion in this calcified undilatable lesion session. Sir.
Message was, Acha. Okay.
Thank you.